Super. So hi everybody, my name is Charlotte Ashton. I am a community nurse specialist in Hertfordshire. And firstly, I want to extend my thanks to you for joining us all this afternoon. I know many of you have had a very busy day at work, so thank you for taking the time to be here. Sickle cell is an area that deserves greater awareness, not only amongst education staff like you guys, but also within hospitals and healthcare organisations. So I really hope this session will be valuable and beneficial to you all. So my presentation this afternoon will focus on the practical steps that you can take to support children with sickle cell conditions whilst they're at school, helping them to stay healthy throughout the school day and achieve their full potential. So I'm going to have just a quick look at the sickle cell conditions. I'm aware that Leanne's and my presentations are going to be similar in some way, but I think repetitive knowledge is good in this case. So sickle cell disorders are a group of inherited blood disorders caused by the abnormal hemoglobin called hemoglobin S. So there isn't just one sickle cell condition, but several related ones depending on the genetic combination a person inherits. So the most common and most severe, which you'll probably have heard of, is sickle cell anemia, which is HBSS. HBSC is usually a milder form, but not in all cases. So we never sell it that your child has been diagnosed with SC and it's a milder form, because often children present more like a sickle anemia with SC. Sickle beta thalassemia is a combination of a sickle cell gene and a beta thalassemia gene. But it's just important to know that sickle beta thalassemia 0 is more severe because they don't produce any normal hemoglobin, your normal hemoglobin being AA. And although these conditions may differ in severity, it's important to remember that all of these conditions share the underlying issue of abnormal hemoglobin S, leading to a variety of complications. And in all these conditions, the preventative measures we recommend are the same for all these children. So we don't differentiate between a condition with the advice that we give. So the symptoms of sickle cell, as Leanne said, was anemia, increased risk of infection, painful crises and organ damage. And I have a picture here of that swollen hand, which is we know as dactylitis. And this refers to the painful swelling and toes, often resembling a sausage-like shape in the context of sickle cell. It's typically one of the first symptoms observed in infants and young children, usually occurring between the ages of 6 months and 6 years. And we know that if you have sickle cell, it can delay growth and puberty. And I've just got a picture there of the chest crises and ulcers, which we often find with the older, younger adults. So no two individuals with sickle cell anemia will have the same symptoms. We have families where there are more than one child within the family that have a sickle cell condition, and it's likely they will present with very, very different symptoms. I have one family where there are 3 boys. One is in hospital regularly, and one of the middle son is, you wouldn't even know he has sickle cell. But the only one thing that remains the same is that sickle cell is an unpredictable condition that can appear suddenly and vary in severity. And the cruel fact about sickle cell is that our patients can follow every precaution and preventative measure, but can still be hit with sudden pain and complications without warning. So we've talked about anemia, and we know that anemia in our patients is not because of the lack of iron in their diet. That's because a normal lifespan of a red blood cell is about 100 to 120 days when the bone marrow replenishes a red blood cell. But in sickle cell, these red blood cells only last between 10 and 20 days. So these children's body is a factory for making red blood cells. So whilst pain is the hallmark of the condition, we know that recent research suggests that fatigue can be a daily occurrence which hugely affects quality of life. And if you're in a secondary school, and it's really important that you share the condition or the child's condition with the PE staff and listen to the child if they can't participate in sport that day, and not wait for a parent to communicate that, because our children could go to school in the morning, say goodbye to their parents, and feel very well, and by 11 o'clock when it's the PE lesson they will feel very tired and not be able to participate. So please listen to the children's voice, and if they are unable to participate, please offer them a suitable alternative inside. Strenuous exercise involving exertion can trigger a sickle cell crisis. So whilst we encourage exercise because the heart is a muscle and needs to be worked, we do want our children to participate, but it is important to listen to the pupil and the parent because they will know their exercise tolerance level. We can get some children that can play a whole game of football, but we can get some children that can merely play half a game without needing to take a rest. So please excuse the pupil if they say they're tired or in pain. Permit extra layers of clothing if partaking in outdoor sports, and then just consider the weather. Exposure to cool wind, cold and wet weather may trigger an episode of illness. But saying that, everyone is an individual, and some people don't have symptoms of anemia at all, and that's why it's really important to get to know the triggers of your particular child. So infection is the most common cause of death in childhood, but a major problem in at all ages. And as Leanne said, that the spleen is the spleen's job is to filter the blood, remove old or damaged cells, and to fight infection. But in sickle cell, sickled cells get trapped in the tiny blocked vessels of the spleen, causing blockages and repeated small injuries inside the spleen. And because of this, the spleen is usually damaged very early in life. And that's why people living with a sickle cell condition are more prone to infections. And these are really nasty infections. So they're 600 times more likely to get a pneumococcal sepsis, salmonella, meningitis, pneumonia. And these infections can be rapid and overwhelming. The risk of serious pneumococcal infections are seen far less in children receiving preventative care, and adherence to prophylactic penicillin reduces the risk of significant infections. So our children, all from sort of early as 6 weeks of age, are on penicillin on a prophylactic dose, so a lower dose than a treatment dose twice a day. And fully vaccinated children have a much lower risk of pneumococcal infections. Early detection and treatment reduce complications. And so we make sure that all our children who have a temperature above 38 degrees have a medical assessment and bloods to ensure that it isn't a nasty pneumococcal infection. And as Leanne said, a complication in sickle cell is that slack cheek, which is the parvovirus, is a serious complication in sickle cell. And that's when the blood can pull into the spleen and cause severe anemia. If you have a child in your school with slack cheek, that our children can still attend school, because the likelihood is that the child is going to be infectious before the symptoms arise. But it's just important that our parents are informed of cases within your school so families can watch for early symptoms and seek medical advice if that child seems unwell. And that's just a picture of the spleen. So the spleen is located to the base of the left rib, and often the child would feel it was really painful. So the parvovirus can temporarily shut down red blood cell production in the bone marrow, and it causes severe life-threatening anemia. So your signs and symptoms would be that the child would have unusual sleepiness, look really pale, very weak, a fast heartbeat, and that would be a medical emergency. And often our children do have their spleen out. So if they've had 2 episodes of splenic sequestration, they will have their spleen removed. So my job is to give the diagnosis following the newborn blood spot. So I usually visit families around 2 to 3 weeks to give that sickle cell diagnosis. But at that point, I can reassure parents that their baby will not develop symptoms for the first 6 to 9 months of age. And that's because fetal hemoglobin is the major hemoglobin in utero and persists for about 6 to 9 months after birth. Fetal hemoglobin is a normal shaped red blood cell and is a protective factor. So when a baby's born, their fetal hemoglobin levels are really high and their sickle blood is low. And between that 6 to 9 months, the fetal hemoglobin drops and their sickle percentage increases. And that's when that child is more likely to become symptomatic. The earlier the baby shows signs of sickle cell symptoms is usually indicative of how severe their sickle cell condition will be. So pain can be anywhere. Pain is anywhere the child says it is, but mostly the child will complain of pain in the long bones, the chest, the back, or the abdomen. Pain is often described as a sharp knife being inserted in a particular area of the body time and time again. It is described as the worst pain imaginable. And sometimes it can be really hard to believe that a child could be smiling and reporting a pain score of 8 out of 10. But please trust them. Our children have had to learn coping strategies to manage painful episodes. They are so resilient and they are so brave. And I think sometimes children just, if they've had this low-lying pain all of their life or those anemia, they forget or they don't even know what life is like without that sort of dull ache or that tiredness. So I usually use this visual with the children. It's a nice visual that shows the cross section of a blood vessel. So at the top, these red blood cells are flowing freely into the blood and moving oxygen in and around the body to the major organs and tissues. And at the bottom, these sickle cells, these hard, sticky, fragile red blood cells are sticking and blocking these red blood cells and preventing them from delivering the oxygen. So we've mentioned before that red blood cells change shape to represent a sickle shape under certain circumstances. And so we know that the triggers are infection, dehydration, stress, cold, excessive heat, sport and exercise. And we'll look at these triggers in more detail and what it means within the school environment. So prevention of painful crises is encouraging our children to drink water. The majority of our children need to drink at least 1.5 to 2 litres of water during the school day. So we just need to ensure that water fountains are working and at the highest state of cleanliness, so pupils are not deterred from using it and risk any infection. Water bottles. Please, can our children have water bottles on a table, or make sure that they're accessible? One school recently used a timer for a child who needed constant reminding to drink. But no child should come home with a full water bottle that hasn't been replenished. And it's also important to note here that people or children with sickle cell can't concentrate their urine very easily, or their kidneys can't concentrate urine very easily. So they produce large quantities of dilute urine and need to go to the toilet more often. So if you're in a secondary school, please issue that child with a toilet pass so that they've got no delay in visiting the toilet and have unrestricted access. So what else can be done? So weather and temperature are important factors in preventing a sickle cell crisis. Children can become ill if they're too hot or they're too cold. So we do support you fully that appropriate school uniform is worn, but we do suggest to families that children wear skins underneath their uniform in colder days, wear a jumper. Some schools are happy for our children to wear a plain coloured, sort of neutral coloured body warmer during cold periods. But it's just important to remember that you avoid overheating of classrooms, maintaining good ventilation, avoid drafts, and making sure that child isn't sat by a window or by a door if you're in a primary school and there's free play. You could agree that warmer clothing could be worn indoors within the school day. If you're in a primary school, scarf, hat, gloves should be kept at school. I always say that if the children are going out in a jumper, out to play, then our children should be wearing a coat, so an extra layer. If the children are out in a coat, our children should be wearing hat and gloves. Avoiding activities outside in the cold or damp. Some children have a real trigger, not all, but some, where it can trigger a crisis if they get damp or cold. So please, permission for the child to remain inside during break and lunch times. And I know how difficult that is with the lack of staff, and how you supervise that, I know can be very difficult. Considering a lift pass if you're in a big school, a big secondary school, for those with severe anemia, or particularly for those that are returning after a severe painful crisis. I think also we consider these, like certainly in secondary schools, where children feel that they have to carry their whole life around with them. So not only are they carrying their books for the whole week, they're carrying water bottles. Some of our children come with bottled water, so they're having their bottled water, but they might be carrying 2 or 3 because they don't know that they can access the water fountain, or they would choose not to. So just, thinking about the position of the locker. Can we get a locker that's more easily accessible? Water play, so just ensuring that if you're in early years and you're using water play, that the water isn't really cold, that the water is warm, and that children aren't exposed to cold water for long periods of time. And once their hands come out of the water, is they're dried, and making sure that their cuffs aren't damp, so they're not walking around for the school day getting a chill. I've put cross-country sport should be avoided. It isn't recommended. I guess in my days, cross-country was getting on a minibus, going to another school, getting cold, muddy, coming back in the minibus. If it's in a school field and the child feels well enough, of course they can take part, participate in that. But it's just being aware that it can be a trigger. So Leanne did touch upon the management of painful crises. So to begin with, fluids. So we're talking about our children drinking lots of water to prevent dehydration, to prevent a crisis. But if a crisis is happening, we know these red blood cells have changed shape and are blocking the blood vessel. So we almost need to increase our fluid to flush, use it sort of as a hose effect, really, and to flush those red blood cells through and get that blood flowing properly. Rest, massage, warm packs, pain relief. Children, all our children should have pain relief held at school. Pain relief does not require a GP label. GPs are very reluctant because of the expense to prescribe pain relief, so that should be on the care plan. But of course, the parents should sign your consent form. We have a low threshold for giving pain relief because pain can be extremely severe and can escalate quickly. Keeping the child distracted, knowing when to attend hospital, and all I ask is avoid ice packs, because obviously that can then be a trigger for a crisis. We talked about strokes being a complication of sickle cell. So children are at an increased risk of having stroke. And as Leanne said, all our children who have sickle cell anemia have a transcranial Doppler, so an ultrasound scan of their brain from the age of 2 to the age of 16 to assess their risk of stroke. But some children will have silent strokes, and this can't be picked up by this ultrasound. So this means there are no signs and symptoms of normal stroke before or while it's happening. So instead, strokes can cause behaviour changes, problems with memory or learning. So we ask for your support here, that if you notice any of these changes, please talk to the parents or us, or your sickle cell service if you've got any concerns about sudden behaviour changes. So a whole host of complications in sickle cell, but as Leanne mentioned about priapism, so you might find little boys wiggling in their seat with this very, very painful erection. As soon as our children are old enough to know, we would talk to them about that. But also, it's something that, we would like you to be aware of. But another complication I just want to bring to your attention is bedwetting. A lot of our children, because they can't concentrate urine, and because we're asking them to drink high volumes of water, suffer with bedwetting. I have a patient who is off to uni in, I think, actually this week, who still bedwets twice a week. And so I tell you that because it can be a factor for fatigue during the school day. They could have an unsettled night, but also just to think about residential trips. So if you're going away, we've had to make suggestions to schools about taking a sleeping bag and putting a pull-up in the bottom of the sleeping bag so that the child can put that on before they go to sleep and then remove it again the next day. So if a child is saying that they don't want to attend a school trip, it's really trying to sort of pick into why the reasons why they might not want to be attending that trip. So urgent medical attention. So we know that all our children should attend A&E for bloods if a temperature is above 38 degrees. Most of our children manage their pain at home with over-the-counter pain relief, but if the pain can't be managed, they are then recommended to go to A&E for stronger pain relief. But if your child is at school and they become breathless, they're complaining of pain in their chest or severe abdominal pain, this priapism, that prolonged erection of the penis for more than 30 minutes, if they become drowsy or unresponsive, severe headache, have any fits or any signs of stroke, then it's really important that you call 999, as these are all medical emergencies. And to reassure you, and I'm sure a lot of you have called an ambulance at school, no paramedic would ever come to school and say you shouldn't have called an ambulance. They might not always take the child to hospital, but it's really important that they get reviewed. So how can you guys help? So ensuring that all children have a school healthcare plan, and that can be done in conjunction with the child's clinical nurse specialist. I think it's really important to try and get those school healthcare plans done in conjunction with the parents, because they know these children best and they will want, special measures put in potentially for that child. We do want our children to participate and be treated the same as every child, but sometimes we just need to put some sort of safety plan in place. Something to talk about is swimming. So swimming, some children have swimming pools, and that's been a trigger for a crisis. We do encourage swimming because swimming is a life skill, but it's really important to have a chat with the parents about that and your specialist. My advice in terms of swimming would be that the child sometimes wears, those full longer swimsuits to keep warm, that they're the last in the pool and the first one out. They're dried quickly, their hair's dried, and they've got warm clothes to put on after swimming. Particularly if they're walking or if they're getting a bus, it's just making sure they've got a hat. Allowing a child to attend for shortened days, particularly after returning from a period of illness. We've talked about discouraging them from carrying heavy bags around school. And it's really important that you liaise with the sickle nurse of that child if they've got prolonged episodes of absence, because we shouldn't be seeing prolonged episodes of absence, and we'd really like to know and to be able to support our children if that's happening. So our aim is to ensure that the child reaches their full potential and feels supported while at school. And we know that stress can be a trigger for a painful crisis. And this could be a new school, a new teacher, falling out with friends, a spelling test. But we know that exam stress can generate a crisis, so we need to minimise this. So it's important to recognise the impact and put strategies in to minimise the risk. So please, can you consider provision for extra time, rest breaks, homework? As a community nurse, I rarely visit patients after school. That's because most of our children can just about manage a school day, and often they come home to sleep because of their anemia. So it's just being aware that they might need longer to complete homework, and that's just keeping that communication open with the child and the parent. And some children do need extra support, and an EHCP plan may need to be considered in some circumstances. So we've talked about treatment. So we know that we prescribe all our children penicillin to prevent that pneumococcal infection. Our children are on folic acid to help with the production of red blood cells. We've talked about hydroxycarbamide. A lot of our patients are now on this medication. So when we talked about the babies where they have the high levels of fetal hemoglobin, that's what essentially hydroxycarbamide does. It increases fetal hemoglobin, which is a normal shaped red blood cell, which doesn't sickle. So it protects red blood cells from becoming hard and sticky. But on this treatment, it requires a regular blood test, which could potentially impact on the school day, along with attending specialist clinic appointments. Leanne mentioned about the bone marrow transplant, which is the only curative treatment option, and you need a good match, risks involved, and the gene therapy, which is the new treatment recently available to children over 12 in the UK. It's a one-time treatment, and in simple terms, it's like repairing or upgrading the body's instruction book so it can make healthy blood cells. And then just to end, remembering the psychological implications of having a inherited blood condition. There is still a lot of stigma attached to the condition, and that's not just necessarily in the wider community, that's within families too.